Hello, colleagues, and welcome to our second of 3 extended sessions dedicated to TB diagnostics in commemorating the World TB Day that we just celebrated. My name is Francis Ochen from the African Society for Laboratory Medicine. Glad to be your host. I have to note at this point that this session will be co-hosted, and I will be introducing my colleague momentarily. The session will run for 1 hour. We will take presentations and get to a question and answer discussions. Please join our discussions through the chat room. Post your questions, comments, or reservations, if any, through the chat space. We do have concurrent language translation services. Please keep on one of either English or the French channel so that you can get all the services. Do not stay on the off channel because that will pose you some challenges. Today's session covers the need to address diagnostic gaps in TB care cascade with critical considerations on the implementation of the MTB XDR assays. And I will allow my co-host to do the introduction of the topic further, and at this point, allow me to introduce the co-host. Our co-host for the session today will be Dr. Gwen Stevens. Dr. Gwen is the Director of Medical Affairs at SafeAid Diagnostics and Life Sciences based in South Africa. Dr. Gwen will introduce the topic, but also the presenters for the day, and then I will join with the questions and answers towards the end of the session. Permit me now to introduce Dr. Gwen.
So thank you to ASLM for hosting this session. My name is Gwen Stevens, and I'm Director of Medical Affairs at SafeAid. And it's my pleasure to host this session today entitled Addressing Diagnostic Gaps in the TB Care Cascade, MTB XDR Assays and Considerations for Implementation. The COVID-19 pandemic has really upended years of progress in the fight against TB, and I don't think I have to remind the audience on this call about that. Deaths from the disease rose for the first time in more than a decade, fueled by a surge in undiagnosed and untreated cases, and we certainly cannot afford to take our eye off the ball. Drug-resistant TB is part of the growing challenge of antimicrobial resistance superbugs. Because of stretched resources during COVID, between 2019 and 2020, the number of people treated for drug-resistant TB dropped by a staggering 19%. Those on treatment for extensively drug-resistant TB registered an even bigger drop of 37%. And the number of HIV-positive TB patients on antiretroviral therapy as well as TB treatment dropped by 16%. SafeAid continues to innovate to ensure that we address the need for TB diagnostics. Our assays focus on direct detection of TB, coupled with drug-resistant testing to guide treatment selection. The MTB RIF assay really put SafeAid on the map in 2020, and this was followed in 2017 by the introduction of the Expert MTB RIF Ultra assay, which improved on sensitivity. And in 2020, we introduced our third and our newest assay, Expert MTB XDR, which is going to be the focus of today's session. I'm honored to introduce 2 very esteemed guest speakers today. I'll introduce both right up front, and the presentations will then follow, and we'll take Q&A facilitated by Francis at the end of both presentations. So first up will be Professor Kogi Naidu. Professor Naidu is Deputy Director and Head of the Treatment Research Program at the Centre of the AIDS Program of Research in South Africa, fondly known by all as CAPRISA. She is an Honorary Associate Professor in the College of Health Sciences at the UKZN University in South Africa, and her contribution to HIV and TB treatment research spans almost 3 decades. She has been a lead investigator in CAPRISA's clinical studies aimed at optimizing treatment strategies for TB and co-infected patients with HIV, and several strategy trials to improve outcomes among patients with drug-resistant TB. She serves on the WHO HIV Treatment Guidelines Committee and is a board member of the South African HIV Clinician Society. Her talk will be followed by Dr. Shahid Omar. Dr. Omar is a medical scientist with specialization in microbiology, focusing on MTB research since his postgraduate training almost 15 years ago. He is currently the acting center head of the Center for Tuberculosis at the National Institute of Communicable Diseases, or the NICD, in South Africa. He leads numerous research activities and currently serves as an expert advisor to the WHO and to the Foundation of Innovative New Diagnostics. So without further ado, I'd like to invite Dr. or Professor Naidu to the stage. I'm going to stop sharing.
Thank you very much to the ASLM as well as to SafeAid for your kind invitation to be part of this forum in honor of World TB Day. So I'm going to be spending the next 15 minutes or so walking you through a presentation that shares some of my thoughts around the new Gene Expert MDR assay, and whether or not it offers, it delivers on the expanded near-patient TB drug susceptibility testing. I'd like to declare a conflict of interest in that I've received in-kind donation of the XDR assays from Fine Diagnostics for a EDCTP funded clinical study that I am responsible for. I will be covering the diagnostic platform for the Expert MTB XDR assay. I would discuss some of the characteristics and performance of the assay, some thoughts around the optimal placement within the laboratory diagnostic workflow, what the WHO reclassification of drug-resistant TB has for the Expert MTB XDR assay, looking at what the added value is of the assay within our existing diagnostic pathway, and we'll make some summary points and conclusions at the end. You've heard very eloquently from Gwen that drug-resistant TB remains a global challenge to TB control efforts, with more than 500,000 incident cases of drug-resistant TB each year. About 80% of those are multi-drug resistance. And amongst those with multi-drug resistant TB, about 20% have resistance to fluoroquinolones. So despite our ability to diagnose RIF resistance, less than 50% of patients are able to receive appropriate treatment based on their resistance profile. So comprehensive drug susceptibility profiles are essential to guide an appropriate regimen selection and essential to curb rising rates of drug-resistant TB that we've observed over the last few years. The current drug-resistant TB diagnosis and susceptibility profiling, we know, is done through molecular-based assays, our line probe assays, complemented by phenotypic susceptibility testing. We know that the current tests are technically demanding, they require advanced infrastructure, and they're usually based in central or national laboratories, restricting access and ease of use. So where does the new assay, the Expert MTB XDR assay, fit into the diagnostic pipeline? Based on the WHO endorsed molecular-based nucleic acid amplification tests, we know that we have tests for TB screening and triage. We have point-of-care tests where no sputum samples are required. And we have the next generation drug susceptibility tests that actually help inform drug choice for the patient based on resistance patterns. Within each of these categories, there's various diagnostics. I will draw your attention to the last box for the next generation drug susceptibility tests. Here, 3 levels of complexity tests have been endorsed by the WHO. The moderate complexity tests in green are your automated nucleic acid amplification tests that detects TB as well as resistance to rifampicin and isoniazid. In red, your low complexity automated nucleic acid amplification test detects resistance to isoniazid, fluoroquinolones, ethionamide, and second-line injectable drugs. And they can be used instead of culture-based phenotypic drug susceptibility testing. Your high complexity hybridization-based tests are for the detection of resistance to pyrazinamide. So you can see that the expert MTB XDR assay fits in under your low complexity automated nucleic acid amplification tests. It's regarded as low complexity as no specialized biosafety infrastructure is required, and only personnel with basic laboratory skills can be used to operate this equipment, and also the equipment that accompanies the assay is also pretty basic. The recommendations by the WHO has been based on evidence of accuracy in sputum obtained from adults with confirmed pulmonary TB. There's no evidence from adolescents and children and people with extrapulmonary TB. However, the evidence has been extrapolated for use in these populations. And what we know is that there were sufficient numbers of people living with HIV that contributed to the tests, that to the evidence, and so the assay can be used quite safely with high levels of efficacy in people living with HIV. So we know that we initially, as Gwen pointed out, the offerings from SafeAid have been your expert MTB RIF that gave us high levels of sensitivity and specificity for MTB detection as well as for rifampicin detection. And the implementation level is supposed to be at a peripheral laboratory level. Ultra added to the offering in that we are able to detect MTB with fewer organisms and also with a high level of sensitivity and specificity. The expert XDR assay now gives you additional resistance detection to isoniazid, fluoroquinolones, your second-line injectables, as well as ethionamide. Again, low complexity and very useful to guide regimen selection for patients. So the previous expert MTB RIF and ultra assays help detect RIF resistance only, so their utility to guide treatment was actually very limited. It was unable to differentiate between viable and non-viable bacteria, leading to high levels leading to diminished sensitivity, especially amongst patients with previous TB, leading to false positive results. So a few papers that have been published that evaluated the analytical performance of the expert MTB XDR assay. The first paper published a while back now was a retrospective study of about 200 stored sputum samples, and they found that the limit of detection for the MTB XDR assay was very comparable to the expert MTB RIF. That the MTB XDR assay sensitivity and specificity was comparable to phenotypic susceptibility testing. The authors then went ahead and compared the assay performance against sequencing. And what they found was the sensitivity of this assay was between 88.5 and 100%, while the specificity for all drugs was about 100%, except for ethionamide. So the drug actually performed very well when, the assay performed very well comparatively to both phenotypic susceptibility testing as well as sequencing. This study conducted in 4 high-burden countries, India, Moldova, and South Africa, looked at the diagnostic accuracy of the expert MTB XDR assay. And so they did a comparison of the assay to midget phenotypic susceptibility testing and whole genome sequencing. They looked at more than 700 sputum samples, and they found, again, a specificity of between 98 and 100% for all drugs, and a sensitivity of more than 90% for INH and fluoroquinolones. The indeterminate rate of the assay was around 3%. It's important to note that the performance for the detection of INH resistance seemed to vary by geographic sites, where they found that in India, the sensitivity dropped to 80% and the specificity was maintained at 100%. And the reason for that was that the WGS comparator identified INH resistance mutations that are not currently included in the expert MTB XDR assay. And so when they did a comparison of the expert XDR assay, it showed equivalent performance to the line probe assay 2, as well as on cultured samples. When we look at the diagnostic accuracy of the expert MTB XDR assay in patients that have smear negative samples, the same study went on to evaluate this question. In a group of about 24% of the total sample size, they found specimens that were negative for smear but culture positive. They found that the assay sensitivity and specificity was not different whether it was sputum or isolates. And that they did find, however, that in smear negative samples, they found higher rates of non-determinate results, 4% versus 2%. And there was no notable difference in the performance for resistance detection based on either smear status. So both smear negative and smear positive samples were able to perform equivalently for the detection of resistance. So that was their conclusion, is that the assay can be performed directly on sputum samples, irrespective of smear status, and have a high diagnostic accuracy for the detection of drug resistance to the specified drugs. So the assay characteristics, there's various points that I have on the slide, but I think what's important to note is that they have very specific mutations for detection using nested real-time PCR, that the time to results is under 90 minutes for the expert MTB XDR assay, that the limit of detection is very similar between the expert MTB RIF assay, in that that assay requires 112 colony forming units per mole, and the expert MTB XDR assay using 136 colony forming units per mole. That it's the operational specifications is between 2 and 28 degrees storage temperature, and generally you need starting volumes of about 2 moles of raw sputum or more than 2 moles of SR buffer treated samples to be used as a reflex assay. So what then is, or how do we place the XDR assay within routine laboratory settings? So on the top row, you see what normally is the workflow for expert MTB RIF testing. 2 volumes of SR buffer is added to a volume of sputum. Then there's the usual vortex, and the sample is then transferred to your cartridge and inserted into the expert system. And you have a readout usually within 80 to 90 minutes. The recommendation is at the point at which you're adding your 2 moles of buffer, that you take a remaining volume and refrigerate it. And it can be stored between 2 and 8 degrees, and that sample can then be used to advance to your expert MTB XDR cartridge and for readout in the 10-color gene expert system. So at the moment, the consideration is that the expert XDR be used as a reflex test after first confirmation of a person's MTB positive status and rifampicin resistant status. So you can see in my diagram, all your pink boxes highlight the added value of the expert XDR assay. The added value of detection of isoniazid resistance, resistance to isoniazid and fluoroquinolone, RIF-resistant and MDR-TB, as well as your pre-XDR fluoroquinolone-resistant TB. The expert XDR here is actually placed so that it replaces line probe assay 1 and 2. We know that in your broken lines, those are your add-on existing tests that can be used to address the shortcomings of the current expert XDR assay, in that phenotypic susceptibility testing to confirm fluoroquinolone resistance in those that are detected with multi-drug resistant TB, as well as those with isoniazid and fluoroquinolone resistant TB, and the phenotypic susceptibility testing for your bedaquiline, linezolid, and clofazimine for the diagnosis of XDR TB. So right now, the suggestion is that the test is used as a reflex test. The problem is that we will still be missing INH resistance detection if we wait for a call out of resistance before we advance to expert XDR testing. And we know that the inclusion of isoniazid resistance in frontline testing will help in the detection of non-multi-drug resistant INH resistance. That the increased access to second-line drug susceptibility testing using Expert Ultra and XDR testing helps with upfront resistance detection. So there is 2 ways of using this assay. One is upfront at the point of making a diagnosis of TB, and the second is as reflex testing. So the big question now is, in 2021, the WHO released new DRTB definitions, and the question around the relevance of the expert MTB XDR assay has now emerged. The old definition called pre-XDR TB as MDR TB plus resistance to aminoglycosides or fluoroquinolones, and XDR TB as MDR plus resistance to aminoglycosides and fluoroquinolones. The updated definitions now is that pre-XDR TB is your MDR and resistance to fluoroquinolones, while XDR TB is MDR or RIF-resistant TB plus resistance to fluoroquinolone and resistance to bedaquiline or linezolid. We know already that the expert XDR assay does not detect resistance to the bedaquiline or linezolid, meaning it does not detect XDR TB. But we do know that the rates of resistance to these new drugs currently is low. And we know that among patients that have already established drug-resistant TB that are known to have extensive resistance, including fluoroquinolones and second-line injectable, that those patients have resistance to bedaquiline at a rate of about 5.4%. So therefore, based on these new XDR TB definition, the current version of the expert MTB XDR assay does not detect the WHO-defined XDR TB. But despite this, this assay seems to cover resistance detection for more than 97% of all drug-resistant TB patients. So how does it add to our current diagnostic pathway? There's several benefits, but there's also limitations and challenges. We've heard about the rapid extended drug resistance profiling that now replaces the traditional methods which are slower. We know that there's limited infrastructure requirements regarding biosafety and technical capacity. We know that there's the add-on of the detection of fluoroquinolone resistance, and fluoroquinolone is important to optimize second-line drug-resistant TB treatment, as well as to protect bedaquiline from emerging resistance. It helps with the detection of isoniazid, which we know is a precursor to multi-drug resistant TB. And knowledge of INH resistance status is important to optimize treatment for INH monoresistance to prevent relapse and drug resistance amplification among patients with drug-sensitive TB. The addition of detection of resistance to ethionamide, of course, may be questionable. However, finding INH-A promoter mutations is important because it can guide high-dose INH therapy. The resistance to second-line injectables is of value in the small group of patients that where the newer drugs are contraindicated or the newer drugs are unavailable. The limitations we've discussed around the limitations to drug resistance detection, the uncertainty about the use of this assay in porcibacillary samples, as well as those with extrapulmonary TB, trace positive, ultra trace positive samples. We really don't have data on that. That the assay detects these hotspot mutations in specific target genes. And so you may actually get genotypic phenotypic discrepancies. And if used as a reflex test, it does not really help us in diagnosing INH monoresistance. There is a lower sensitivity and specificity for the detection of ethionamide resistance because of the limited number of gene targets that's included in the assay. And of course, now their preference is to use all oral regimen, so it's less desirable for us to be aware of second-line injectable drug resistance. So in summary and some concluding remarks, we know that the current diagnostics are limited with respect to the accuracy, the time to results, and accessibility, warranting patients to have multiple clinic visits, costs to the patients, as well as upstream losses in the TB care cascade. That the current system misses a substantial proportion of patients with INH monoresistance, and that this new expert MTB XDR assay addresses several gaps in the current DR-TB diagnostic pathway and care continuum. And it may help us expand resistance testing access or access to resistance testing and ensure appropriate treatment initiated for those that are undiagnosed or not yet on treatment. Of course, it's not the full solution. We do now need substantial efforts to design an optimal test that ideally incorporates both MTB detection as well as simultaneously detecting resistance to INH, RIF, and the newer drugs, the fluoroquinolones, the linezolid, and bedaquiline on the first available sample. So while we have come far in the last decade with respect to TB diagnostics, we still have further to go. Thank you very much for your attention. Over to you, Chair.
Thank you very much, Dr. Naidu. I'm going to call directly on Dr. Omar to share his slides and continue. Thank you.
Good afternoon, colleagues. And my name is Shahid. I will be presenting to you evaluation of the assay and the possibilities of integration into a national diagnostic program, a South African perspective. So I think the previous speaker, Professor Naidu, has covered most of this, but just to recap, that drug-resistant TB is a global health threat, and if not controlled adequately, could take us back decades in terms of the gains we've made with tuberculosis over the last few years. And in 2018, the WHO has endorsed a shorter regimen, which has reduced treatment to from 18 to 24 months down to 9 to 12 months. And in this regimen, both the fluoroquinolones and second-line injectables are critical components. And therefore, it is really important to understand the resistance for these drugs. And that's the rationale behind the development of this cartridge. The current practice in South Africa is susceptibility testing for these drugs, or based on a line probe assays, which are the molecular tests. Each methodology comes with its own caveat. Phenotypic testing takes 4 to 8 weeks to get a result, which is quite a long time. And then molecular methods, the current ones in place are, despite being faster, are restricted by the limited targets and performance. So the WHO listed a TB drug susceptibility test that can detect the most common first and second line drugs as a high priority. And these should have the following profiles. It should be fast, it should have low technical skill, it should require minimal infrastructure. In response, SafeAid has developed the Expert XDR assay. This has improved the capability of molecular detection to resistance for isoniazid, fluoroquinolones, second-line injectables, and ethionamide. The processing is exactly the same as the MTB-RUF assays, the Ultra and the previous version. The test is done in 90 minutes approximately from sample addition to result. However, a major difference is that it does not run on the same platform as the MTB-RUF assays. It requires a 10-color module. That is the key difference between these two technologies. The reason it requires a 10-color module is because there's more targets than the Expert Ultra, and therefore it requires more fluorescent detection, light emission detectors, so that it could read more targets. So let me take you through the first study. The first study was basically to determine the performance of the XDR assay for predicting resistance compared to the reference standard of phenotypic testing, which is culture, midget culture in our case, as well as sequencing. And the second is to look at the detection of MTB by the Expert XDR cartridge compared to the MTB-RUF assays. The objectives, of course, is the sensitivity and specificity when we're looking at drug resistance detection. Then also the Expert XDR has the capability of differentiating between low-level and high-level isoniazid resistance based on genetic targets. And then finally, the positive percentage agreement and negative percentage agreement. So how many samples that are positive by the Ultra would be positive by the XDR assay, and the same for negative isolates. The study site was the Center for Tuberculosis, which incorporates the National TB Reference Laboratory for South Africa. And then the sample types used were frozen archive, de-identified concentrated sputum specimens that have been pre-characterized for phenotype and genotype for the drugs of interest in the study. Samples that had been previously thought were excluded from the study. This is an overview of the processing, the test procedures. So every day before evaluation, at the start of the day, 3 controls were run: a mutation control, wild type control, as well as a negative, which this was positive. Only if controls passed for the day would we move on to the evaluation process. For the evaluation, samples were thawed until they reached room temperature and tested on the XDR assay. In the event a result was non-determinant, the test was repeated and repeated once only. The reference method for susceptibility testing I mentioned was midget DST for the phenotype and sequencing of the targeted regions. In South Africa, we performed whole genome sequencing. And then for MTB detection comparison, we compared it to the MTB-RUF assay as well as the MTB Ultra assay. In this presentation, I will only focus on the Ultra, as this is the cartridge in use in our environment. For the results, we enrolled 322 specimens. Of these 322, all received an Expert XDR assay. A phenotypic DST was successful for all. Sequencing was completed, whole genome sequencing was completed, and then a proportion was tested on the Expert MTB-RUF assay and a proportion on the Ultra assay. Overall, the non-determinant rate was 3.1%. These were due to cartridge errors and failed tests. But on repeat testing, these were all successful, so we were able to analyze the complete set of 322. The first thing we will look at is the performance of the XDR assay in the smear negative and smear positive groups. So for culture positive, smear positive group, I just want to put on my point. For the smear positive, culture positive, we had a sensitivity of 99.5%. This is expected as all molecular tests do really well in this category. For the culture positive, smear negative group, it was 94.7%. This was exceptionally well. In general, it is much lower than this, and for the XDR cartridge, it's performed really well. The overall performance was 98.3% for sensitivity and 100% specificity. The second result we look at now is the performance of the XDR test compared to the Expert Ultra for the detection of Mycobacterium tuberculosis. And what we find, the positive percentage agreement was 99.5%. So the test was accurate at calling almost all samples positive by the Ultra assay as positive on the XDR assay. And the negative percentage agreement was 100%. So whatever was negative by the Ultra remained negative on the XDR assay. Let's look at the sensitivity and specificity for each drug compared to the reference standard phenotype and the prediction of the XDR assay. So for isoniazid, we had a sensitivity of 90%, fluoroquinolones 90%, the aminoglycosides amikacin 96.2%, kanamycin 84%, capreomycin 84%, and ethionamide 64.7%. The specificities were extremely high, above 98%, in most cases 100%. When we look at the performance of the XDR compared to sequencing, we see a higher sensitivity. The sensitivity for INH goes up to 98.5%, fluoroquinolones 95%. The injectables all average about 98%, and ethionamide 97.6%. The reason we're seeing a higher sensitivity is we're comparing the targets detected by the cartridge versus the targets, the mutation patterns in the targets only by sequencing. So that is the performance, overall performance of the XDR cartridge, which was exceptional in our environment. And these were all tested using South African samples. And just to move on with the discussion, I need you to sensitize you to the current DR reflex algorithm used in South Africa. And this is really important to understand where would the XDR assay actually fit into our program. So every gene expert R assay, every sample that is RIF resistant by gene expert, we're expected to collect a second specimen. The second specimen is decontaminated and a culture is set up on widget, and we perform the line probe assays. If the line probe assays fail from the direct sputum sample, we will then perform the line probe assays of a midget culture. So in South Africa, we generally see about a 30% failure rate in the first line from a direct specimen. So 30% would be reflex to culture. So we repeat testing. And then based on the outcomes of the line probe assays, we will then make decisions in terms of what is done phenotypically. In most cases, we would test levofloxacin, bedaquiline, clofazimine, and linezolid on most samples. So South Africa has already started deliberating on the implementation strategies for the expert XDR assay in our program. And looking at it, we came out with 3 potential strategies then, and also looking at the phased approach of implementation. The first is the previous slide I've explained to you, the DRTB reflex algorithm we use for every RIF-resistant isolate or every RIF-resistant specimen. And this would be the ideal position to actually perform testing using the XDR. So the XDR assay would, as Professor Naidu pointed out, replace the first and second line LPAs generally done in our routine services. This would be the first point. Then we would go a bit broader, where we'd collect a second sputum, and the second sputum would perform testing on any sample that is ref resistant, and then reflex to the XDR cartridge. So the difference between strategy 1 and strategy 2, strategy 1 would only be done at culture-based sites, so sites that would be performing DST thereafter. In strategy 2, we would decentralize further, so we would move out a bit more into every site that got a GeneXpert Ultra, and then do testing from that point immediately to a XDR cartridge in that facility. And then strategy 3, and this is the broadest reach, is basically to a XDR on all GeneXpert positive. So we'd look at not only ref resistant, but ref susceptible TB, and perform the XDR testing as well. So we would have a comprehensive phenotype based on genetic markers. And this will also allow us to detect isonized monoresistance, which we currently estimate to be between 7 and 10% in South Africa. So this is just a cartoon of exactly what the XDR cartridge would be replacing. So it would take out this arm of the reflex testing as well as this arm, and this will all be completed by the single cartridge. Because we're seeing such a huge success rate in terms of concordance between everything that is positive by an ultra cartridge is almost positive by a XDR cartridge. So in terms of infrastructure considerations, so the main issue is that the ultra cartridge uses a different platform compared to the XDR assay, which requires a 10 color, and the ultra is currently running on a 6 color. So what we then did is a study to determine how compatible is the ultra cartridge on a 10 color module system. And we've run it on both clinical as well as pre-characterized ref-resistant isolates. So we wanted to see, using a 6 color instrument versus a 10 color instrument, what is the performance of the ultra in the G4 cartridge in terms of detecting MTB as well as ref-resistance. And what we found is that there was a 98.4% agreement for the detection of MTB between the two colors, and then a 97% agreement for ref-resistance. So basically, what we have to consider when implementing the XDR assay is that it uses a different platform. It uses a 10 color instrument compared to a 6 color used for the ultra. So what we did in South Africa and Milan is look at the performance of the ultra and the G4 cartridge, the MTB ref assays, on the 10 color instrument. Because SafeAid made claims that there is backward compatibility, means that the ultra would work perfectly fine on the 10 color. But this we did assessment on clinical specimens, 320, and then we also used a characterized panel of isolates to look at performance for ref resistance.
Go ahead, Shahid. I think it's just somebody in the background.
Okay. So what we found is the agreement for the detection of MTB between the 6 color and 10 color module was 98.4%. And majority of the discordance was found to be in favor of the GeneXpert 10 color. These isolates were detected as trace and missed by the 6 color. And then there was only one in favor of the G4. So the 10 color had a higher detection level. In terms of agreement for ampersand resistant calling, 97% agreement was seen between the two, the 6 color and the 10 color instrument. And discordance was mainly related to ref indeterminate or not false susceptible or false resistant calls. And it was a 50-50 on both platforms. So these are the conclusions from the studies. And basically what we've seen is that there's a good sensitivity and specificity for resistance prediction, more than 90% for your fluoroquinolone isoniazid as well as second-line injectables. We do see a lower resistance prediction for ethionamide, but that is expected because we're only looking at a shared target with isoniazid, which is the INHA promoter, and not really the primary target, which is ETHA. So, but all in all, still giving a decent sensitivity. The performance of the DST was lower than sequencing, and this just shows that the reference that we use in these studies is really an imperfect reference. It's sometimes sure. So PDST does not always have to be the gold standard, and it may be that cases that PDST misses resistance that could be detected by molecular assays. The expert XDR was really accurate in differentiating between resistance levels to isoniazid. And I think the slide has not been showed, but there was a 99.5% agreement between high and low. And the concordance between the XDR and ultra was 99.5%. And this therefore translates that you're able to reflex from a positive expert ultra test and move directly to an XDR test, because 99.5% of the cases would be detected on the XDR assay.
Omar, our
yes.
time is fast spent. If you could just wind up, thank you.
Okay, so this I've mentioned before, there's a good concordance between the 6-color and 10-color instrument. So that means that you could actually use a 10-color instrument for both the Ultra and the XDR cartridge. And then in terms of the future use in South Africa, we're actually looking at using it to replace DR Reflex. So we'll replace the first-line assays and then move to a point where we could reflex samples from the Reflex directly from the same buffer isolate. The improvements that the XDR would make to our program is huge, because currently we have a median time of 14 days to a result using the line probe assays in South Africa, despite it being a molecular test. And this could really be reduced to hours and maybe just a day or two. So the expert XDR, as we know, is fast, robust, and specific, and would really add value to our program as the expert Ultra MTB rough assays have changed the landscape for diagnostics. This too would contribute to effective management of drug-resistant TB patients and allow clinicians to make informed choices when putting patients on treatment regimens. Thank you so much.
Thank you so much, Dr. Gwen, Dr. Umar, and Professor Naidu. Very informative and exciting presentations. I hesitated to fast track the presentation because of the information that was coming through. Colleagues, our time is fast spent. We have a few questions that we can deal with. The rest will come through our resource center that we always do the posting. If I could just take 2 quick questions before we wrap this up. Sapela is asking, with the expert MTB Reef Ultra, when the test is stress, that's the test results is stress, should that be the final report? Or if you can then go on to do the reflex testing to determine XDR?
I think we can give that question to Professor Naidu.
Naidu, yeah, any one of you can take it.
Yeah,
and I can
thank you.
Please go on.
Thank you very much. So South Africa and the NICD under Dr. Shahid have a trace algorithm that we've been using thus far for your MTB, Expert RIF, and Ultra. And this is really based on the presence of previous TB and symptoms. So in an asymptomatic individual with previous TB, we need to do culture and susceptibility testing to confirm your presence of TB as well as your rifampicin resistance. In those that are symptomatic with the previous TB, you would need to start TB treatment and then also concurrently do culture and susceptibility testing. In people with no previous TB but have symptoms, we need to start treatment. Those that have had no previous TB and are asymptomatic, and the clinical features are not suggestive of TB, we would need to investigate further. So therefore, it stands to reason that if you are planning to start treatment, you actually would need to do a Reflex Expert XDR to confirm your resistance pattern and help direct the choice of drugs. I hope that answered the question. Thank you.
Thank you, Professor Naidu. One last question, and you can still take this. Mekonen is asking, what are the molecular characterization currently used to identify MDR-TB and XDR-TB? Did you hear me, Professor Naidu?
Sorry, I thought that was for Dr. Omar. So currently we do phenotypic susceptibility testing. It's extended susceptibility testing to help us establish the presence of fluoroquinolone resistance as well as the resistance to bedaquiline and linezolid. So that's what's currently available in South Africa. Dr. Omar, if you want to add to that.
Okay, I can take the last, which is just an appreciation. We have a question coming from Lucas on how we can deploy some of these technologies to remotely located places. And we had a very fantastic response from Peter, giving the example from Uganda, where we have an elaborate sample referral mechanism that moves samples from remote locations without testing platforms to sites where testing can happen. And thank you, Peter, again for sharing this. A few other questions that we cannot respond to will be responded to through our online platform. Please visit there. My colleague David already posted the link to our resource center, the online resource center. Just one last comment from Dr. Gwen. I will let you summarize for everyone your closing remarks for today.
Well, I just want to thank ASLM for hosting this very valuable session, and a big thank you to Professor Naidu and Dr. Omar for their insights. This is a very exciting time for us as this product is launching globally. And a colleague, Rojeko, has actually just put a link in the chat. So if you need any more information or have any questions associated with this product and its implementation in the region, please feel free to reach out to us on that link. But just again, a big thank you, and thank you very much to ASLM particularly. Thanks, Francis.
And thank you, everyone. And colleagues, thank you for being with us for the last 1 hour. Just to confirm that the resources from this session will be made available as and when they're available on our resource center. Please check it out for your future references. This was the second of our 3 eco sessions dedicated to the commemoration of the World TB Day. Please look out for the 3rd that should be in the offing. We wish you the best of today, your night, and the evening ahead of you, depending on wherever you are. Thank you, and bye-bye for now. For those who may need their certification, please, the code is displayed. Pick it out and get to the ASLM Academy and get your certificates to demonstrate your attendance of today. Thank you again, and have the best of the rest of your hours ahead of you. Bye-bye for now.